Let's do a dummy's guide to the HPG axis, the hypopituitary gonadal axis. Hence we call it the HPG axis because that's a bit of a mouthful. So it breaks down like this. The testicles produce testosterone. Testosterone has a really short half-life, between 10 minutes and 100 minutes. So essentially, it needs to get bound to sex hormone binding globulin. Shock horror! No, let's not have SHBG, let's reduce it. No, actually, you want a nice healthy SHBG because you need to remember the primary purpose of testosterone replacement therapy is growth and repair. And that needs to happen, obviously, predominantly when you're resting during anabolic phases, but also throughout the whole day as well. So whilst the day is predominantly catabolic, it's not solely catabolic. So you still have to have that ability to have anabolic processes occur and catabolic processes occur. So you cannot speak in absolutes. So SHBG, you want a nice healthy SHBG. You don't want to tank your SHBG. So the SHBG is produced by the liver. What else? Albumin, another protein produced by the liver. That weakly binds to testosterone. But you've only really got around 2% that's free to do what you want any old time. So you can't actually use testosterone. You can only use free testosterone, dihydrotestosterone, and estrogen. Now, estrogen feeds back to the hypothalamus and pituitary to say, I've got enough or I haven't got enough. So if the estrogen's high, you've got plenty. So your brain goes, cool, we don't need to produce LH and FSH. If you don't have adequate estrogen levels, the hypothalamus responds and says, right, let's send gonadotrophin releasing hormone down to the pituitary to tell the pituitary to release luteinizing hormone and follicle stimulating hormone. Luteinizing hormone is the hormone that tells the Leydig cells the testicles produce testosterone, and follicle stimulating hormone is the hormone that tells the Sertoli cells to produce sperm. Is it as simple as that? No, because we know that luteinizing hormone has a significant role in fertility as well. So it appears that luteinizing hormone is far more important than follicle stimulating hormone, but they're also both necessary because otherwise they wouldn't be produced. But as you know, we've had 17 successful pregnancies to date using testosterone, enanthate, and HCG, which mimics luteinizing hormone. So that's the HPG in a nutshell. Let's talk a bit more. So what do we do in testosterone replacement therapy? Well, we replace the testosterone, and we know that testosterone suppresses the hypothalamus and pituitary. So we're not going to be sending luteinizing hormone and follicle stimulating hormone down to the testicles. Now, is that a problem? I don't want kids. It's fine, I don't need HCG. Well, you do. It's not all about fertility. Luteinizing hormone has other roles. So there's upregulation of the hormones down from pregnenolone, and also there are LH receptors in the brain, and there's a subsequent dopamine response. And people on HCG stroke LH, they feel a sense of well-being and an improvement in libido that you do not feel on testosterone monotherapy. So when we talk about testosterone replacement therapy, we're essentially bypassing the HPG axis, and we are creating our own HPG axis. So do no harm, testosterone monotherapy. We know it causes suppression of the hypothalamus and pituitary, and so you don't send signals down to the testicles. And so if you did want to be fertile, then HCG is integral. We induce azoospermia by testosterone monotherapy. So in my mind, it's negligent not to have HCG in your TRT protocol. It is integral. The peculiarity is you can be prescribed testosterone replacement therapy in your 20s and 30s, and the NHS will be quite happy to prescribe testosterone after they found obviously a formal diagnosis, which you should be doing anyway, but they won't prescribe HCG. Now, do no harm. It seems rather nonsensical that we know a medical therapy will cause infertility through its mechanism of action. However, they will not give you the medication that treats that negative side effect. Fertility, quite important. So, interesting, NHS. Why would you not do that? Is it because there's a misconception that it is associated with anabolic steroids because the bodybuilding community recognise the importance of HCG? Should we have this closed door just because the bodybuilding community understand the importance of HCG in maintaining testicular function? No, we should take evidence, information from all sources and critically analyse it, and then make it legitimate. Shock horror. What a crazy radical thought. Just because a piece of information comes from a dodgy area, it does not mean that you should discount it. They may be speaking in truths. Now, when it comes to the use of HCG, they are. Now, do they use it properly? And the answer is no. But that's why you need a savvy clinician who understands the HPG axis, who understands physiology, biochemistry, etc., to take what was originally known, found, used by the bodybuilding community and legitimize it. It's not rocket science. You shouldn't shut doors just because you don't want to have an association with something that is dodgy. You should take that information and learn from it because you can utilize it and make it legitimate. It shouldn't be rocket science. So we had no, I'm not going to say it. So yeah, when we think about testosterone replacement therapy, it's quite simple, really. Replace the testosterone. We know that it suppresses the pituitary, so we replace the LH with HCG, which mimics luteinizing hormone. It isn't rocket science, but there's an aversion to the idea that we can utilize HCG because it's used in the bodybuilding community. That's absurd. Do no harm. So we know it works because we have 17 guys. Well, it's not 17 guys because 2 of our guys have had 2 children using testosterone monotherapy and HCG. I don't say monotherapy, a single ester is what I meant, sorry. So it makes sense from any which way you look at it. So who's in the right, who's in the wrong? I know who's in the right. So we don't utilise it in the same way that the bodybuilders use it. We use a lower dose, and obviously we are titrating that dose according to effect. So The HPG axis, in simple terms, what more do you want to know? Comment below.